So we're going to talk a little bit about Turner Syndrome 101. And what I based this talk off of is a number of years of having discussions with parents with their child when they are first diagnosed with Turner syndrome. It is an incredibly overwhelming first visit. So this is what I feel like in the initial visit. I feel like I am backing up and dumping a load of information. And I will tell you, in the more than 15 years that I've been doing this feeling never goes away. And so I'm hyper aware of how that must feel when you're coming in with your kid with a brand new diagnosis. And we're talking about an enormous number of systems and topics and possibilities. So this feeling is normal, and I feel it on my end as a provider, right? Like I can see the overwhelm in people's faces. But what I always come back to is that these topics and the issues and all of the screening, they are repeated time and time again, and should be, right? And in every visit, we're trying to tailor what we're talking about to that particular individual, and we're trying to hone in on what are the most important things for that child or that adolescent or that adult. So let's talk a little bit about Turner syndrome and what defines Turner syndrome and how common it is. So Turner syndrome happens in about 1 in 2,000 or 1 in 2,500 live-born girls. And we're going to talk about what this means, but about half of girls with Turner syndrome are what we call sort of classic 45X, and I'm going to explain what that means. And again, part of this talk is not just based on my counseling of families over the past decade and a half, but also the questions that I get asked fairly frequently in those initial visits, because everybody wants to know, what is my karyotype? What does that mean? What I get asked pretty frequently, like, what kind of Turner syndrome do I have? And what we're talking about here is something called a karyotype, which tells you kind of what type of genetics does that individual have. So in every cell in your body, inside the nucleus is the genetic material that gives instructions for what that cell is doing, okay? And in typical cells, you have 23 pairs of chromosomes, and 2 of them are sex chromosomes. So in females, 2 of those are X chromosomes, and in males, there's 1 X and 1 Y, okay? And so on the left-hand side of this is a typical karyotype. So you have 46 chromosomes, and 2 of those are X's. And on the right-hand side of this slide, there is a missing X chromosome. So when somebody tells you your karyotype is 45X, it basically means that you're missing one of those typical 46 chromosomes, and that missing chromosome is an X chromosome. This is kind of what it looks like. The last one was just a bit of a cartoon drawing, but these are actually what the chromosomes look like. And the way that geneticists identify each of the chromosomes is they each have a very specific banding pattern. So you can see, if you look at them closely, they have stripes like zebras, and each of them is unique. And so you can identify the striping pattern. You can say, this is chromosome 1, this is 2, this is 3, and then the X chromosome. Okay, so, but there are other forms of Turner syndrome. So like I said, about half of girls, if you check their cells just in their blood, which is typically what we do, all the cells that are looked at are 45X in about half of girls and women. But the other half have other forms of genetics. And so we think about these as either mosaic karyotypes, and what that means is that you'll have cells in the blood that are classic 45X, meaning they're missing one entire X chromosome. But in mosaic patients, you actually have 2 types of cells. So when you look at some of them, they're missing an X chromosome, and other ones have 2 normal X chromosomes, okay? So that's 45X/46XX, okay? So that is a mosaic karyotype. There are other issues that we can see. This one that I have the yellow box around is missing a chunk of one of the X chromosomes. So that is that you still have 46 chromosomes, one X that's more typical, and one X that has a deletion. And that deletion can be big or small. Very, very small deletions are not considered to be Turner syndrome. And those kids typically are just short, but they don't have all of the other issues that we see with Turner syndrome. The next one that we see sometimes is something called a ring chromosome. So you have one typical X, and the other X, what happens with the other X chromosome is that bits of each of the ends of that chromosome get chopped off, and the ends are a bit sticky, and they get stuck together into a little ring, okay? The other thing that we see, this last one on the right, is something called an isochromosome. And what that means is that one of the X's is typical, and the other X actually has one missing half, and the other half is mirrored, okay? So you functionally have a missing part of the X chromosome, and you double the other side of the X chromosome. So that's called an isochromosome. There's about 5% of girls and women with Turner syndrome who actually have sort of what is, quote unquote, a male genetic part, but they are fully female. So externally, outside they're female, inside they're female, but some of their genetics have kind of male genetics. So as a rule, when somebody has all of the cells in their blood missing one entire X chromosome, we think of them as more affected, meaning they have more things that go along with Turner syndrome, but that's not across the board. It tends to be that way. So how do we typically see these girls diagnosed? Like what leads pediatricians, what leads internal medicine docs or gynecologists to diagnose Turner syndrome? So this is actually from our population. This is a paper that we published, and you can see that a little less than 10% are actually diagnosed before they're born. That's the very left-hand bar. A little more than a third are diagnosed at birth. Another third is diagnosed in childhood, most of the time because those girls are not growing well. And then in puberty, the diagnosis is often made because puberty is delayed, and often because those girls are short as well. So sometimes the combination. If Turner syndrome is diagnosed at birth, sometimes we can see specific features. So in this baby, for example, you can see a lot of the extra skin on that baby's neck. You can also see that baby's ears are a bit low set and they're rotated backwards. So those are some of the things that we look at. Like I mentioned, sort of the low hairline, low set ears, sometimes a small jaw. Swelling of hands or feet, this is pretty bad. This is pretty severe swelling. We don't typically see it this bad, but that's another clue to a diagnosis of Turner syndrome. And then we often think of heart defects, and what we think of is left-sided heart defects. I'm so sorry, I meant to, and it's not backing up. It's okay. So if a baby is diagnosed with specific heart defects, that should trigger the thought of Turner syndrome in that physician. So the most common feature is short stature, right? And the reason I'm starting to talk about this is because it has implications on what we do for that girl, right, in terms of growth hormone. This growth chart, it's not used very much anymore because most medical centers in this country now use an electronic medical record like Epic right? So they don't have these growth charts, but this is a growth chart that we used to have a nice paper copy of in clinic that we used to plot by hand, somebody's growth over time. And what this shows, if you look at the sort of white and green swath, that shows the average growth of somebody with Turner syndrome who has never been on growth hormone. And the red lines show kind of what more typical growth of somebody who does not have Turner syndrome looks like. So that's the 5th, 50th, and 95th percentile are the 3 lines of the more typical growth. And so what you can see here is that girls with Turner syndrome are shorter even early on. This is at age 2. And then they just look like they fall further and further away. And then this average line leads you to about 4'8" without growth hormone treatment. And that's obviously country specific. You know, in different countries, there are different average heights. 4'8" is about the average in the US. So, and this is a little more detail. I get asked this sometimes, is why are girls with Turner syndrome smaller? And the reason is because there is a gene on both the X chromosome and the Y chromosome. So both males and females have 2 copies of this gene. And when you have one missing copy of an X chromosome, you're also missing one copy of this SHOX gene. And it causes short stature. It leads to the growth plates not being typical. So, and the other thing that it leads to, because I mentioned that the growth plates aren't normal, is that it can sometimes lead to some of the other bony issues that we see in girls and women with Turner syndrome. So, for example, this is something called a Madelung deformity. It's also called a bayonet deformity. And sometimes we also see this is something called cubitus valgus, where her arms look like they're bent, but they're not. That's kind of how much she can straighten them. This is showing kind of that short 4th bone in the hand. That's a very typical thing. All right, so let's talk a bit more about growth. Let's talk about it right from the get-go. So babies with Turner syndrome are typically born a normal size, but they are slightly smaller at birth than typical girls. And the growth slowing starts early. So it's basically you're born small at birth, and then you really start to fall off the growth curve pretty early. And I think I already mentioned this earlier, I got ahead of myself, but about 4'8" is the average adult height when you're not treated with growth hormone, which is about 8 inches or so below sort of a US average. So what do we do about it? And a lot of you know this, we use growth hormone. And growth hormone, if somebody in this room has not yet had their daughter or started on growth hormone, it's given by a nightly injection. And I say this to families when we're first talking about growth hormone. It's a very, very short needle. They're the same needles that are used when you give yourself insulin. So it just goes under the skin into the fat. And kids tolerate these injections incredibly well for the most part. Typically, we will watch growth really closely and start growth hormone somewhere between 2 and 6 years of age. The youngest I have ever started somebody on growth hormone is about 13 months of age. And the reason for that is because she was already quite small and just tanking off the growth curve, and I did not want to lose any more ground in her. But there's a good range. So a lot of girls, I can hold off until they're more like 3 or 4. Even if they're below the growth curve or kind of hanging out just around the lower end, but then we wait for, either them falling off or they get into the sort of toddler years, a little bit older toddler years, where I'm thinking, the parents don't have to chase that kid around with a needle at bedtime every single night, right? Overall, what you can expect, and this is average, you can expect about an inch extra for every 2.5 years of treatment, okay? But most girls overall will get about 2 to 3 inches in the long run, and that's extra height on top of what she would have been. So for a lot of girls, I am so sorry. I cannot go backwards. That's all right. For a lot of girls, that means that we can potentially get them into the lower end of normal. Often, though, we can't really get to, let's say, where we would have expected that girl to be based on her family's heights, right? So if mom is 5'8" and dad is 6'1", you would have expected that girl, based on that combination, to be quite tall. And even those girls, we sort of are able to maybe get them into the lower end of normal, 5 foot being what we consider the lowest end of normal for an adult woman. So how do we do this? So that girl gets started on growth hormone, and we adjust the dose based on how she's growing and blood work. We start the growth hormone at a dose that's kind of an educated guess, right? So we use why we're treating and how big that girl is to kind of guesstimate the dose, and then we adjust it really based on how that individual girl is growing. We stop growth hormone when that child is nearly done with growth, which for us means really impressive growth slowing, or when her bone age is 14 or greater. And a bone age is basically an x-ray of your left hand. You have growth plates. Growing kids have growth plates all over their body, but there's just a lot in your hand. So we can look at the hand x-ray and look at, 3 growth plates basically in every digit and 2 growth plates in the wrist. And so we have a lot more to look at to see how old do those bones look in that girl. So that's what we're looking at when we decide when to stop growth hormone. What are the side effects that we sometimes see with growth hormone? These are very rare. Okay, so this is like a needle in a haystack. The first one that I talk about with families is a separation of the growth plate of the hip, and that's called slipped capital femoral epiphysis, or sometimes we say skiffy. And those girls will have either hip pain, or sometimes they will feel it as knee pain, and eventually they're not going to walk. They're going to want to limp and then not walk. I will tell you, and for as long as I've been seeing girls with Turner syndrome and treating them with growth hormone, I've had one girl who had this complication. When it happens, it's a big deal. It's a surgical fix that has to happen, and then we can restart growth hormone once that's done. This is a side effect that girls with Turner syndrome are at slightly higher risk for, even without growth hormone, but they're also at higher risk when they're treated with growth hormone, but it's still a tiny fraction of a percent. The other thing that we see is an increase in the pressure in the fluid around the brain. Girls who have that side effect will have headaches and changes in their vision. So this is something I very deliberately tell patients when they get on growth hormone. I want to know about headaches and changes in vision, and I want to know about hip pain or knee pain. Those are the big ones. Let's switch gears. Let's talk about heart, okay? So overall, there's heart issues in about half of girls and women with Turner syndrome. They're what we call left-sided heart defects. So you sort of have the right side of the heart that collects blood from the body, then sends it to the lungs to be oxygenated, and then it comes back to the left side, and the left side is responsible for sending it back out to the rest of the body. So we think about left-sided heart defects. One of these, the classic one that everybody thinks about, is something called a coarctation. On the left-hand side, you guys can see that big vessel that comes out of the heart, that's the aorta, is like a candy cane, and it should be pretty smooth. In this candy cane, you can see how not normal it is, but really what we're looking at is kind of this like almost like somebody put a rubber band around that little part of that aorta right here. Bicuspid aortic valve. So the aortic valve, which is the valve that leads out of the heart and into that candy cane structure, normally has 3 different parts to it, almost like a Mercedes symbol. And in bicuspid valve, 2 of those are sort of stuck together. They're not separate. Aortic dilatation, so that just means that that bottom part of that candy cane is getting wider. High blood pressure is a really common issue, and we pay very close attention to blood pressure when we see patients in clinic, because we really want to be very careful about treating it when it happens, because it can increase the risk of that aorta widening. And then the kind of feared complication is aortic dissection, which means that the blood that's coming out of the heart kind of gets between the layers of the wall of the aorta, and it can be very, very dangerous, but it is exceedingly rare. It's just slightly more, it's more common in girls and women with Turner syndrome than it is in the general population, and it also happens quite a bit earlier. So in women who do not have Turner syndrome, this happens more like in their 80s. But in women who have Turner syndrome, the age that it happens is quite a bit younger. Let's talk about kidneys. So there's a lot of different things that can happen with the kidneys that make them not typical. This happens in maybe a third or more of girls and women with Turner syndrome. This is the classic one that every medical student is taught about. It's called a horseshoe kidney, where instead of having two separate kidneys, you kind of have a connection at the bottom, and that's what that picture is showing. But you can also have the kidney being duplicated. You can have smaller kidneys or one kidney that doesn't form at all. Most of the time, this doesn't cause an issue, but if it does, it can cause urinary tract infections or high blood pressure. And so I always tell people, if that girl has a problem in terms of the kidneys when we do an ultrasound, if she has unexplained fevers, like if, they're like, oh, she has a fever, but she doesn't have a cold or she doesn't have anything else, I tell them, you need to tell your pediatrician that they need to check for urinary tract infection, because it should be high on their list to make sure that that's not what's going on. Let's talk a bit about puberty. So you'll hear this term about streak ovaries, and basically what that means, so when a fetus is formed who has Turner syndrome, she's actually formed with typical ovaries, and what happens to them when she's typically still in mom's belly is that they kind of undergo almost an early menopause even before she's born, okay? And what's left of that ovary is kind of a little streak scar, and that's what a streak ovary is, okay? So what we do to check if a girl can go through puberty on her own, or if her ovaries are not going to be able to do the job that they should do, we check something called an FSH, and we usually start to check this around 10 or so. The FSH is the signal from the brain that activates the ovaries to tell them to go into puberty. And you can imagine if the ovaries aren't doing their job, the brain is going to be screaming a louder signal at the ovaries saying, make hormones. Why are you not making hormones? And so that FSH is going to be sky high, okay? So that's what we're looking for to tell me I'm going to need to help with puberty in that kid. I'm going to need to pretend to be her ovaries, essentially. But there are girls with Turner syndrome who can start puberty on their own, right? So it's about 1 in 10 or so of classic 45X girls who can do some puberty on their own. Now that doesn't necessarily mean that they can go all the way through. So sometimes we see that they have a little bit of breast development, but then it kind of stalls out, and then I need to jump in and help from there on out. In mosaic kids, remember we talked about mosaic kids are the ones that have some 45X cells and some typical 46XX cells. There's a much higher percentage of those kids that go into puberty on their own, and then a much smaller percentage of girls who actually reach bleeding on their own. So most girls, I need to help with puberty, but I don't do that unless I know that that girl is unable to do that on her own. And I do that watching their exams, I do that watching their labs over time. We also get another level, and that's called an anti-Mullerian hormone, and that tells me whether there are eggs in that ovary. And that's a really important thing, because if there are, then that family and that girl has the option for potentially saving those eggs, because we know that even if there are eggs in that ovary at a particular time, they may not be there in a few years because that girl is at risk for essentially an early menopause. And so sometimes families choose to go through a fertility preservation process where they go to a gynecologist who has expertise in this, and they can harvest eggs and save them until that girl is ready to have children. So what do we do in terms of puberty? How does this happen? So basically, once I know that I'm going to need to help with puberty, I am starting hormones at age 11 or 12. And the way that I describe this to families is there's no magic to it. I am trying to pretend to be the best ovary that I can. And I start at little doses of estrogens and I work my way up over a couple years. And then, so the estrogen that I'm giving, and that's usually by a patch. Climera is the one that I'm showing here. That's just one of the brands of transdermal. So that means estrogen that's given by a patch on the skin. So we're basically working our way up on that dose, and it's going to do a lot of important things in that girl's body. So number one, it's going to give you the changes that you would expect with puberty, right? So breast development, kind of the change in body shape that's more kind of adult female. But the other things that it's going to do is it's good for heart health, it's good for liver health, and it's good for bone health. So we see all of those things. The last thing that's going to happen is that the uterus is going to grow. And within the uterus, estrogen starts to make that blood lining inside the uterus grow. And we don't want it to just grow and grow and grow without having any way to clear it out. And so at that point, at some point, we add a second hormone in to help clean out the uterus. And so that girl is going to be on a weekly estrogen patch, and then 10 days each month, she's going to take a progestin pill, and sort of mostly toward the tail end of that 10 days or just afterward, she's going to have her bleed. So we're kind of dealing, kind of quote unquote, with the side effect of the estrogens, which is that it makes that blood lining build up. Let's talk a bit about bone health. So we know that girls and women with Turner syndrome are at higher risk for weaker bones and also for fractures. So we want to make sure that that vitamin D level is normal, and we want to make sure that we're giving that girl estrogens because, like I mentioned, estrogens are what keep bones strong. And so we want to make sure that that girl gets the right amounts of estrogen and the right duration of estrogen. So we've actually had adult patients who come in and who have not been on estrogens in 15, 20 years because they didn't have a provider who knew about Turner syndrome. And I worry about that girl, that adult's bones. The way that we measure bone strength in women with Turner syndrome is something called a DEXA, and it's basically a fancy x-ray, and it tells us kind of how strong do those bones look based on this x-ray. Let's talk a little bit about development and behavior. So most girls and women with Turner syndrome have normal intelligence. Sometimes, so very early on in this talk that we were talking about the different genetics that somebody could have, and one of those that I mentioned would be a ring chromosome, right, where there was like one normal X and the other one was like a circle. So girls with a ring chromosome have a higher risk for having delays in their development. And so if somebody comes to see me and I know that that's what their genetics looks like, I'm going to be paying very close attention to how that girl is developing. I'm going to be sending her for testing to make sure that we pick up on issues early so that that girl can have early intervention and we can maximize her potential. This is something you guys probably know, but the things that we see are, difficulty with different sort of visual motor, visual spatial skills, executive function, planning, problem solving, and sometimes interpreting nonverbal communication. By the way, I'm just gonna put a little asterisk next to all of this, that every girl is different. And I have girls who they come in and I'm like, how did 11th grade go? And and the parents are telling me and the kid is telling me, I got straight A's and I'm on honor roll and I'm doing great. So these are things that I look for and I think about and I screen for, but every girl is so different and there's such a big variety of how girls and women with Turner syndrome experience these different things. Particular strengths. Is it okay if we take questions at the end, if that's all right? Yeah? Okay. Particular strengths are in verbal memory, receptive and expressive language, and also word knowledge. We do sometimes see higher rates of poor self-esteem, sometimes immaturity, social isolation, and anxiety is an incredibly big issue for a lot of girls and families that I take care of. Let's talk a little bit about other things that I see with Turner syndrome. So autoimmune diseases, and particularly we see a lot of thyroid disease. Most of the time when we talk about thyroid disease, we're talking about the thyroid gland not making enough thyroid hormone, but sometimes I have patients whose thyroid glands actually make too much thyroid hormone. They're both autoimmune diseases, but they're different, and the labs that we see look different. We can also see celiac disease and inflammatory bowel disease. Type 1 diabetes is more common in girls and women with Turner syndrome. And this is especially true, I don't know if you guys remember, but when we were talking about the genetic piece of things, when we were talking about that kind of mirrored chromosome, where there's the short piece is missing and the long arm is mirrored. So this is something that we particularly see of higher risk in girls with an isochromosome. And that's part of the reason that I explained all that in the beginning, because it is important to know what your genetics are so that we know what things to pay particular attention to. I include some of this only because I've been asked about it in first visits before. So for example, I have been asked in first visits before, can you tell me, what are the things that look like somebody with Turner syndrome? Okay, and so I put this here only because I want families to know, and it's a really hard thing to talk about in a first visit too, where, I don't want to other that kid, right? I don't want to make them feel like, oh, this is wrong. But I've been asked those questions before, and I think that's always a tricky one. But the sort of classic features of somebody with Turner syndrome: the low set ears, small jaw, and you can see all that in this girl who, by the way, I think in the last 20 years, every time I Google images for Turner syndrome has been on the internet, and if you Google Turner syndrome, she will pop up. And I don't know how old she is right now, but she must at least easily be in her 20s or 30s. You can see her kind of wider neck. Those are things that should have alerted a pediatrician to screen for Turner syndrome. Sometimes we see nail changes in Turner syndrome, so a lot of times the nails will be sort of scooped upwards. Moles are really, really common, so lots and lots of moles. It happens over time too, so you can get that more as kids get older, but there's not an increased risk of skin cancer, but we do need to monitor those moles over time. This is just a picture of a girl with many moles, and she also has a bit of a wider chest and widely spaced nipples. That's something that we see. High palate is very, very common, which can often lead to a lot of feeding difficulties in a newborn with Turner syndrome. A lot of ear infections. Hearing loss is incredibly common and can be incredibly difficult and affect quality of life in a really major way. And I will tell you, I'm going to tell you a real life scenario where I just saw one of my patients maybe 3 weeks ago on a Wednesday, and we were talking about the fact that, I'm asking about hearing, do you think overall you can hear well? Have you had ear infections since the last time I saw you? And she said, oh yeah, just had a hearing screen at school, and it was normal. And I said, yeah, okay, well, we haven't had a hearing test in quite some time. And I asked the audiologist next door, do you think you can fit her in, do an audiology test? And we did it, and that girl had such profound hearing loss that she needs hearing aids. So I'm just putting that out there. It's incredibly common, and sometimes the screening tests that are used kind of outside of our sphere aren't perfect. So we just have a really high level of suspicion. ADHD is much more common. I think I mentioned nonverbal learning disabilities, but again, a normal intelligence quotient. So this is going to be kind of like what we do for everybody with Turner syndrome, because like I said, we want to make sure that we're catching the things that we need to pay attention for that individual girl, right? And so we tend to screen everybody the same, and then over time you kind of hone it down to what you need to pay attention for that individual. So everybody gets a look at their kidneys with a renal ultrasound. Everybody gets a look at their heart. Everybody gets a look at the conduction of their heart with an EKG. Every year, we tend to get thyroid. IGF-1 looks at the growth hormone dose so that I can adjust it to that individual girl. Other labs that we get on a regular basis, we look at liver function, which can be off in girls with Turner syndrome, girls and women with Turner syndrome, but we don't really know why. And I have a fellow who's working with me right now so that we can at least try to start learning about why liver function tests can be abnormal. Cholesterol we get at least once during childhood. AMH is the hormone that I mentioned before, that's anti-Mullerian hormone to look at the pool of eggs in the ovary. FSH is the hormone I mentioned earlier that tells me whether that the pituitary gland is screaming a signal at those ovaries saying like, why aren't you making hormones? Hemoglobin A1C, it looks at diabetes, it's a screen for diabetes. CBC looks for anemia. And vitamin D I mentioned, we need to make sure that we have normal levels so that bone health can be maintained. And then sometimes we get estrogen levels when we're going through the process of puberty. Sometimes we get cardiac MRIs to get a better look at the heart in the teenage years. And then regularly we look at the heart again, right? So we look at either an echocardiogram or an MRI, and then also an EKG, and that gets done usually through cardiology, but sometimes the pediatric endocrinologist is the one that's ordering it. And then in terms of treatment, we talked about a lot of these things already, right? So growth hormone until you're done growing, right? So only in childhood. Replacing puberty hormones, right? And replacing adult sex steroids, that's what we call puberty hormones. And then thyroid, if that girl or adult needs it. We do a lot of hearing and vision screening. And then the neuropsychological, sorry, that's a typo. That should be neuropsychological testing to look for some of those learning issues that I already mentioned. And then I mentioned DEXA, which is that measure of bone strength. And typically we do that after we've gone through the process of puberty, either from inside that child, if her ovaries are working, or from outside, from me. Let me just very quickly mention our Turner Center. So our Turner Center was established 20 years ago. And we have 4 docs who see girls and women with Turner syndrome. That's obviously me, and my very good friend and colleague, Dr. Swager, who's the newest addition to our Turner Center. Dr. Sheenan is she's also a diabetes person, which is lovely because in my field, it's often divided. So there's people who see patients with diabetes and people who see other endocrine stuff. I am a person who sees all the other endocrine stuff, and so she's both. And so if we have a patient who has Turner syndrome and diabetes, she's my main person. And then we have something that's incredibly rare, which is Dr. Carruthers over here in the corner, who is trained to see both kids and adults, and she sees all of our adults with Turner syndrome, she's a unicorn. There's not that many of somebody like her in the US. We also have our lovely nurse coordinators who are actually here. If I see Jenna, but I don't see Lauren. Oh, she ran to the restroom, yeah. So our nurse coordinators, we have a dietitian with us, we have social workers, and then we have specific doctors that we refer to in cardiology for the neuropsychological testing, and also psychology when girls struggle with anxiety, depression, OCD, all the things that we see pretty commonly. We also have a specific gynecologist and a fertility specialist, and also ENTs that know a lot about Turner syndrome. And these are my little mice. These are my 3 mice. So the one on the left just graduated from high school, and the one on the right is just coming home from camp today after 4 weeks there. So I'm open to questions. Anything goes. So
I'm Suzanne Kisavat. How much vitamin D is too much vitamin D, or can you never have enough vitamin D?
it's a very good question. So it depends a little bit, okay? Depends on your levels, right? So if you are vitamin D deficient, typically what we do is we give bigger doses to soup you up, right? So there's a little bit of debate on what's a normal vitamin D, okay? There's one body of evidence that says you should be above 20, and there's another group that says you should be above 30, okay? We tend to shoot for 30 because there's very little risk in shooting for over 30, okay? If you are below 20, and if you're below 10, that's pretty impressive. And those people, we actually give 50,000 units a week for 3 months to soup you up, and then we kind of take you back down to the levels that should keep you normal. And often we recheck vitamin D to make sure it went up, okay? If your vitamin D is normal and you're just trying to keep it there, then probably you can handle somewhere around 1,000 or 2,000 units a day. And that should keep you pretty normal. What I will say is it is hard to overdose on vitamin D, but it is possible. And if you do it, it puts you at risk for kidney stones. So you don't want to do it. Because what it does is you take too much vitamin D, it's going to make you absorb every tiny little bit of calcium from your diet, and all of that is going to be peed out, and it can create calcium stones. So I hope that answered it. It was a little bit of a, yeah.
My name is Michelle. Would it be advisable to do a reverse T3 and a reverse T4?
So most people do not need a reverse T3 or a reverse T4. And there's really, so let me explain what I mean. So the way that thyroid hormone is broken down, when you go from something called T4, and the reason it's called T4 is because it has 4 iodines on it, okay? And T4 is broken down into T3, which has 3 iodines on it in different places, and that's active thyroid hormone. Reverse T3 has 3 iodines on it, but they're in a slightly different place than T3, okay? The only time we tend to get reverse T3s is when somebody is sick and their thyroid function is off, and we're trying to figure out, is their thyroid function off because they're sick or because they really do have real thyroid disease? So reverse T3 is only helpful in that scenario. It's not helpful to tell you anything else about how your thyroid gland is working. And for most people, a TSH is the only thing that you need to check to make sure that your thyroid gland is working. And the TSH is a little bit like the FSH that I mentioned before. So the TSH is the signal from the pituitary gland to tell the thyroid gland to work. And if the thyroid gland isn't making enough thyroid hormone, that brain is going to be screaming a signal at the thyroid gland saying, make more thyroid hormone, you're not making enough, and the TSH is going to be high. Does that make sense? Okay.
Hi, my name is Danielle, and I'm a mom to a Turner young woman. And we've been through this journey for a long time, but this is great to go back to the basics, because back then I didn't absorb a lot of this. So a couple of questions related to growth hormone in particular. Are there other benefits of growth hormone besides growth stature?
Yeah, it's a good question.
And are women and girls with Turner growth hormone deficient or resistant? And is there any talk of continuing it in some way? And then my last question is related to Hashimoto's thyroiditis, which seems to be more common. So I just...
Sure. So let me tackle the first 2 questions about growth hormone. Excuse me. So the first question was about, are they growth hormone deficient or resistant? So most girls are not growth hormone deficient. They make plenty of growth hormone on their own. And what we're trying to do with growth hormone is just tank them up, right? So usually the way that I describe that to families, I'm like, you have a sink and it has a level of growth hormone and it's totally normal. What we're trying to do with growth hormone is fill it to the top without overflowing it, okay? So we are trying to push growth as much as we can with growth hormone. There's probably a bit of evidence that girls with Turner syndrome are a little bit growth hormone resistant, but it's not significant. So I don't tend to think of them as significantly resistant to growth hormone. You asked another question and it fell out of my head.
The benefits besides
Oh, yes,
growth. for
yes,
growth
yes, okay. Most of the benefits are just related to height, okay? And when I counsel families about the choice of growth hormone, because it is a choice, it's not a have to, I'm talking to them about, like, this is not a have to, we're talking about height, not health. And really the caveats to that, what I say is that I think the considerations of not doing growth hormone are, it is probably a bit harder to function in a world that is sort of built for people that are between, some certain range of heights. And so you might need step stools to reach upper cabinets or adjustments in your car to reach car pedals, things like that. The other thing that I mention is that it's probably a bit harder to maintain a healthy weight when you are 4'8" rather than when you are 5'1", right? Because somebody who's 4'8", 4'9", has to eat a vastly smaller amount of calories to maintain a healthy weight than somebody who's 5'2", right? There's been some literature over the years that talked about does it have an effect on the heart or muscle? There's nothing strong that says this is going to benefit you a ton beyond growth. And in my own practice, I will tell you, I probably have somewhere between 5 and 10 families who choose not to do growth hormone. And I think that is a very valid choice, right? I think it's not a have to, like I said. And then you have a question about Hashimoto thyroiditis?
The percentage of Turner girls who have that.
Yeah, so it's just under about a fourth, right? So it's really, really, really common. And we screen for it a lot, right, every year. But I'm also, every time I see that girl or adolescent or young adult, I'm asking questions about symptoms of thyroid disease so that I know, do I need to screen that girl sooner than that year? I'm also looking at her growth really closely, right? Because I want to know, does her growth make sense? Is she responding to growth hormone the way she used to, or have I suddenly seen a slowdown that tells me, gosh, I wonder if something else is going on? And that might be thyroid disease.
Hi, my name's Laurel, and I have a daughter with TS, and she's 14. We just found out about a year and a half ago because we really had no idea. And I was wondering, what you mentioned something with hearing. So if it's not really good at the school, where do you suggest they get a really accurate hearing test?
Yeah, so an audiologist is where, it's sort of the gold standard of hearing testing. Most pediatric and adult hospitals should have an audiology program. When I send somebody to audiology, I can send them just on their own to audiology. There are also ear, nose, and throat docs that have audiologies that they're kind of nested under that. And so sometimes you have to access the audiologist through an ENT doc.
Okay, thank you.
Yeah.
Hi, my name is Tom. I have a granddaughter who is 3 years old today.
Oh, happy birthday.
On the symptom side, doesn't really have any of the visual symptoms that you put on the chart, but I noticed that she's extremely, at the very least, limber, or she is maybe even double jointed. She can get into the craziest positions, and she's very comfortable doing that. So I'm wondering if that is a symptom.
Her sort of bendiness.
Mm-hmm.
Probably not. I bet that's just inherent to her, right? It's just something about her that's different, and whether she had Turner syndrome or not, she'd probably be that way. So, yeah.
Hi, my name's Kathy, and I have a daughter with Turner syndrome. She had many ear infections as a child and had ear tubes many times.
Yep.
And I wasn't
Very
aware
typical
that
story.
we needed to follow up on hearing loss as an adult. So I was
Yes.
wondering, is that a side effect of the hearing infections, or is there something else in adulthood
Yes, it's
that
an
can cause
excellent
that?
question. So you can have hearing loss that is related to a lot of ear infections, but you can also have hearing loss that is related to a problem with the nerve that goes to the ears. And so it's really important to continue to have hearing screening into adulthood and throughout adulthood. Because like I said, you know, when we look at things that affect quality of life, hearing is right up there, right? So she does need regular hearing screens throughout, even if she stopped having ear infections. And even if overall she's telling you she seems to hear okay.
Okay, any other questions in the back?
Hi, my name is Lisa. Am I really loud?
No, not at all.
Okay. I have a niece who is 4 years old, and she was born with a single X chromosome and some XY chromosomes.
Okay.
Is that odd?
No.
Or,
So
okay,
it's,
because
it's-
my sister had the blood work, was told she was having a baby boy,
Right, yeah.
went in for the ultrasound, and was told she was having a baby girl.
Yes. So, and I'm assuming you didn't say this specifically, but she has Turner syndrome, right? She's
She has
diagnosed. Yes.
Turner's.
So she is of that like 5% of girls and women with Turner syndrome who has some Y genetics, but externally and internally, completely female, right?
Yes.
So it's not unheard of. We have lots of girls who have that. And there's the question with those kiddos is whether there's a risk of her ovaries becoming a sort of benign tumor.
They
that
were
can-
removed
They
already.
were removed, good.
By the
Okay.
time she was 2.
Yes, and that's most of the time, that's what's done, is they're removed because of that risk of the benign tumor, which can then very rarely become a cancer.
Yeah. Okay, thank you.
Yeah.
My name's Julia, and I'm a grandma to a little 5-year-old Turner's. She is having ear tubes put in next week, and my daughter's concern, is there a concern for anesthesia and any extra care that you have to worry about when they're doing ear tube surgery? And
Yeah.
also tonsils, is it common to get tonsils out with
Yes.
Turner's at the same time?
Yes, so yeah, tubes are easy, fast. The anesthesia is usually very, very safe. But because of some of the changes that you can see differences in the way that the airway is shaped, that anesthesiologist needs to at least be aware that that's her diagnosis. But most kids do absolutely fine with the anesthesia. She'll see, both of my girls, by the way, had tubes. So like, even as a doctor, I remember being stunned by how fast it is. Like you are literally leaving the waiting room and he's already coming out to be like, we're done. So it's really fast. It generally isn't general anesthesia, meaning like they're not putting a tube in her airway. They usually just keep her like a little bit sleepy so she won't remember and then wake her up pretty much right away. And oh my goodness, I'm sorry. I didn't get much sleep last night because I wasn't feeling very well, but I don't remember your next question. Oh, the tonsils, yes. Tonsils and adenoids out are very, very common as well. Sleep apnea is more common in girls and women with Turner syndrome, and so sometimes that's the initial way that it's treated. Sometimes they also recommend tonsils and adenoids because of recurrent ear infections, because that can sometimes help prevent them if that's part of the structure issue that's causing the ear infections. But yes, tonsils and adenoids very, very commonly out. Sorry, I didn't, can you,
No worries.
You would say the tonsils are part of sleep apnea. If she's a big snorer, that would help, like the snoring and
Sometimes,
sleeping?
yes. Sometimes, yes.
All right. Please help me. Well, thank you, Dr. Little, for her time today and for her knowledge. So we do have more sessions going on, continuing in this room and the other ballrooms. Please take a look at your program and enjoy the rest of the conference, everyone. And thank you, Dr. Little.
Thank you, guys. It's really my honor to be here. So thank you.